Welcome everybody to this webinar. I'm just going to let some other people in while we're talking. This is the third one of these we've done. Previously, they've been reasonably successful and well received. This week's webinar is about cochlear implants, and we have an excellent panel that Ian has assembled. Well, everybody's assembled themselves, really. Let me just get back to the slideshow for a second. So the first correspondent is Natalie from Paris, and unfortunately, all of the photos I have of you, Natalie, you're wearing a cycling jersey. And anyway, Natalie works at Necker Children's Hospital in Paris. She's a pediatric ENT surgeon who has an interest in airways as well as cochlear implantation. The second one, I've got lots of pictures of James in a jersey. I think this one was taken in Norway, James. James is a pediatric ENT surgeon in Oxford and has an interest in implantation. And this is the only one I've got of Ian Bruce in a jersey, so that I'll put the slightly better one of Ian Bruce on instead. Ian is a professor of pediatric ENT in Manchester Children's Hospital and interested in otology and implantation. And tonight's chair is Steve Broomfield, my colleague from Bristol, who I'm sharing the sofa with in the Bappo studio. And it's a 2-meter wide sofa, so we are socially distancing. And in case anybody wanted to know, I have got COVID positive antibody tests, so I'm feeling pretty safe about things at the moment. I know it's not supposed to matter, but it does. So I'm going to hand over to Steve. Steve.
Well, thanks, Mike, and thanks to the panel for agreeing to be grilled this evening on the subject of cochlear implants. So what we're going to do is we're going to essentially run through the implant process, starting at the beginning, and discuss some of the sort of most interesting topics that come up as we go. So I will just go down to the first slide and we can start talking about things.
Okay, bear with me, Steve.
That's right. So we can continue the discussion while we get the slides up, because the first slide is we're going to talk about newborn screening. So as you know, this has been universal in the UK since 2005. So I was just going to start actually, for interest, ask Natalie about the situation in France with newborn screening. How long has it been universal and what's your sort of approach to it?
So in France, it has been voted. It's in the law now since 2012, and it has been progressively spread on the whole as a nationwide. And now it's really effective since 2014. So we have like 10 years. We are 10 years behind you. But now it's well organized. And so it's been a big progress for us as ENT and seeing children just after diagnosis very early on.
Yeah. And do you, like us, do you have different screening protocols for high risk and low risk babies?
Yes, we have the maternity have the choice to choose otoacoustic emission or ABR. But when they have high risk or when they are in high risk maternity, they have to. It's mandatory to use the ABR.
And do you think, or the other panel members think, that there's an argument for doing ABR in all babies?
I think that there is, and in Australia they do ABR in all babies.
Yeah, that's where I'm coming from, because I worked
and I think that, I mean, it's more labour intensive, but it does allow you to capture a few oddities, such as auditory neuropathy, who might be missed if they're a well baby and don't go to the neonatal intensive care unit. The UK protocol, slightly different from France, is that you basically get an otoacoustic emission if you're a well baby, and then you get an ABR if you spend more than 48 hours in the special care baby unit for any reason. And the reason for that is that babies that have gone to the special care baby unit have a 10 times higher rate of sensorineural hearing loss, permanent childhood hearing loss, than children who who are from the Well Baby Clinic. That's why there's the slightly different screening. But and for most babies, it probably doesn't really matter. But there is a situation where you can have a normal otoacoustic emission, but still a baby with a hearing loss, if the problem lies in the synapse from the inner hair cells to the cochlear nerve or within the cochlear nerve itself. And they can be missed if you just do otoacoustic emissions. But it's a pretty small number, but it needs to be borne in mind that any screen has its holes, whether the patients don't attend or the screen isn't correct for every baby.
Yeah. Ian, maybe I can move the slide on and bring you in on the next one. And that's the issue of CMV. I noticed something that we've worked on before. Do you think we'll ever get to a position where we're screening routinely for CMV? Or because we know it's a leading cause of the non-genetic deafness in children, in particularly unilateral deafness, but we don't currently screen mums or babies for it routinely. What's your view on that? Do you think that will change?
I think all of these screening protocols have potential, or be they established or new, have potential drawbacks. So for CMV, yes, it would be helpful to know if a child's been exposed to CMV infection. However, well, it would from the perspective as well, because you can get a late onset hearing loss. So I suppose, do you want to have that information? Will that help parents? Bearing in mind they may never develop a hearing loss and there'll be subsequent screening. I was thinking when I was listening to you talking before, I think one of the other things to put in the hat is we've all been aware of the 100,000 Genomes Project, which has recently finished recruiting in the UK. And I wonder whether some aspects of or limitations of current screening protocols may be addressed if we can think about genetic screening as well as an adjunct to current universal newborn hearing screening, sort of screening for mutations associated with progressive hearing loss, things that newborn hearing screening doesn't pick up. So, yeah. Or alternatively, identification of pendrids, patients with a wide vestibular aqueduct. Now, I appreciate that if they fail newborn hearing screening, then they're likely to get an MR, but when does that MR occur? So no system is perfect.
And in fact, I was going to ask Natalie this again to get the French perspective. In terms of genetic screening, do you routinely refer for genetic assessment, or is that something you do on a sort of case by case?
No, for each children, no matter which hearing loss they have, for all of them, we look for CMV at a very early stage, just to not miss it, because afterwards, when they're past 1 year of age, it's very hard to assess to be sure it had been congenital CMV. So we look for CMV right start at the beginning. It can be for moderate or unilateral, bilateral, any kind of hearing loss, and we have the genetic testing very early on, as early as we can. I mean, there's some delay in the assessment because we don't order ourselves. They have to go through the genetic clinic. But we are even if it's unilateral, even if it's a partial hearing loss, they all have the same screening for genetic.
That's interesting.
I think another point, Steve, sorry.
When we assess, when the children are, even if children are asymptomatic for CMV, but they have a hearing loss, we discuss the treatment if the child is less than 1 year of age. So there's impact for it. It's very important to get this information because there's some impact for the child.
Yeah. And when you talk about treatment, do you have access to the immunoglobulin treatment?
No, it's antiviral.
Antiviral.
Yes, antiviral.
Yeah. Okay. I'm going to move on slightly. Unless, Ian, did you want to come back in there with?
No, I was just wanting to clarify as well that when we're talking about genetic screening, there are different things you can do. So the majority of the time in the UK, you're looking for connexin gene abnormalities, but it may well be with next generation sequencing, exome sequencing, that and new novel gene panels that we can really widen the net, if you like, when we're thinking about genetics.
Yeah.
And in fact, occasionally, a lot of the time, genetics doesn't actually change what you do, but occasionally it does. So I had a case recently of a chap who was in his early 20s, but age 11, he developed an auditory neuropathy. It was all very peculiar. No one could really get to the bottom of it. And he'd gone from pillar to post in different countries and eventually in the UK about what was going on with him. And he came to see us and we sent off some bloods for genetics. And 2 years later, the geneticist wrote to us and said, we've got it. And actually he's got an adult onset or a late onset auditory neuropathy. There's been 2 other cases in Korea, and now the guy's going to have a cochlear implant. So in fact, sometimes the genetics does make a difference in ways that you can't expect. And I think I'd agree with Natalie, they've all got to go off, and the old way of testing for connexin is going to be soon, I think, rather passé, and basically they'll all go off for whole genome screening, and then we wait and see what comes back.
Yeah. Right, I'm going to move on slightly. If anyone is interested in learning more about etiological investigation for hearing loss, there are very detailed guidelines on the British Association of Audiovestibular Physicians website. So if anyone wants to look more at the difference between unilateral and bilateral testing, there's a lot of detail on there. So I'm going to move on now to talk about imaging. Just quickly, in terms of preference, certainly an MRI scan is important to look for the auditory nerve. We know that. But do you normally leave it at that, or do you go for CT scan as well routinely, or only in selected cases? Perhaps start with...
I would only use it a CT scan in selected cases. So if there was a diagnosis of craniosynostosis or marked plagiocephaly, flattening of the back of the skull that you can see in some children who've spent quite a lot of time in a supine position, perhaps on the neonatal intensive care unit, for example. So I would order it in those situations, but I don't tend to, or we wouldn't organise it otherwise.
Yeah, I think that's right. And in terms of age, Natalie, do you try and do the MR early so you don't require a general anaesthetic? You can do it with the baby.
Yes, now it's our reference imaging is MRI. We just do the CT in very specific cases before surgery for cochlear implant, or when we have a transmission. When it's neurosensory hearing loss, that's the first imaging is MRI, and we do those before the age of 12 months. And we have the best images looking also at the brain at the same time when they're past 6 months of age. Before this, sometimes you have a false positive for a nerve, 8th nerve anomaly. So we're very cautious not to do it too early. But when there's a cochlear implant in the program, then we will organize the MRI before. But any case, if we can, before the age of 12 months, just to explore the inner ear and the nerve and the brain.
And presumably you're doing these under general anaesthetic then?
No, it's no anesthetic. We have a specific program with our department. They don't do any general anesthetic unless it's very seldom. It's maybe 5% of children.
That's good. Okay. Just going to move on again, if that's okay. Unless anyone wants to add anything more on the sort of preoperative imaging. That scan, by the way, shows enlarged vestibular aqueduct.
Just while you're moving on, the only thing I would say is that if the MRI is normal, then that's, and you're thinking of, for children who you're thinking, I'm going to do a surgery, I'm going to do a cochlear implant. If the MRI is normal, then you're home and hosed. You don't need a CT scan for surgical planning. But if the MRI is abnormal, then often a CT scan is really, really useful. First of all, it gives you more information about the inner ear. And particularly, I find it helpful in cases where there's hypoplastic or small cochlear nerves, because sometimes they can be really hard to see in a small IAM. But the CT scan, you can measure the size of the cochlear canal, which is quite a useful marker, a surrogate marker for whether there's a nerve there or not. Generally, if there's a good cochlear canal, then largely your nerve will be okay.
Good. And we may come back to that issue of hypoplastic nerves later if we get time. So we'll move on for now, and we'll talk about the issue of glue ear, because as we know, that can affect the results from the auditory brainstem response. So, in terms of management, Ian, maybe I'll come to you first on this. What do you think about management of this? And would you put grommets in routinely? What's your sort of protocol?
So I take it this is a child that's under assessment for a cochlear
Yes, correct.
implant.
Sorry, yes. Yeah.
We are, or tend to be, guided to a certain extent by the confidence of the audiologists in the thresholds that they've been able to acquire. And you've also got to decide what improvement you're likely to have in the thresholds if you were to drain
You've gone a bit
fusion. So we'll often, hello?
Yeah, your sound broke up a bit there. Could you just start?
Sorry.
Again?
Yeah, so it's a little bit about what the thresholds are and how near to being outside criteria that the child is, and your confidence of your audiology, really. So if they're well in criteria and they've got glue ear and they're not making adequate processing in terms of speech, language, social development, education, depending upon their age, then it really is unlikely that draining the middle ear fusion will make a significant difference to their thresholds or enough difference to their thresholds that a conventional hearing aid is going to help them. So we have on occasions, and we still do, particularly, for example, if one ear is in criteria and one ear is out, we will certainly be thinking about draining the glue and seeing what thresholds we have without it. But
and if you do
a little bit disappointed, if you like, we end up draining the effusion. They're just outside criteria, and then 6 months later they're in criteria with their grommets in, and you just think, okay.
Yeah. And if you do put grommets, do you just leave them in place when you do the implant surgery, or do you like to remove them, which I know is some people's preference?
I now would leave them. However, the way we were trained was in Manchester was to take them out and graft the eardrum.
James and Natalie, or James first maybe, any different view?
No, very similar. The only thing I would say is if you see that picture and the CT or MRI scan shows an abnormal inner ear, there is the possibility that it's actually CSF and not glue, and that should go through your mind. If the inner ear is normal, that's very unlikely to be the case. It's worth considering if there's an anomaly of the inner ear.
Good point. And Natalie, any other thoughts?
Yeah, I would have a slightly different point of view. I've seen dramatic changes in very early child, very before the age of 12, dramatic changes in ABR thresholds before and after the grommets. And we performed grommets very early on just to assess the hearing test and make sure. And the second, and also it prepares for surgery, because when you have surgery with glue ear or not dry ear or inflammatory, it's very hard. The surgery is much harder and you have much more risk of complication. So anyway, you have nothing to lose to have the grommets very early on and then reassess no matter what. So you're very confident and you prepare the surgery at the same time.
Great. Well, thanks. So we'll move on again now, talk about the criteria, which last year in the UK, or in England and Wales, NICE issued a modification to the previous guidance. And I'd just like to ask, initially, perhaps from the UK perspective, Ian and James, what impact do you think this has had so far? Clearly in adults, it's been a very, very big change. Has it been such a big change in children, do you think?
Well, I can say from Manchester that our experience is not. Has been that it hasn't really made the staggering changes that perhaps some people are going to expect. But that represents variation in how the old criteria were applied. So roughly speaking, you might have half the centres in the UK that if they're assessing a child, they would look at each ear individually. So I'm not suggesting that they're putting cochlear implants in for single-sided deafness, but if you had one ear that was in criteria and the other one had a severe loss, then again, you will implant that child often a little bit later, because you need to be certain that they can't make adequate progress with conventional hearing aids. So you have that group of centres, and then you have others that applied the old criteria more strictly and said that your hearing had to be in criteria in both ears. So Manchester, we assessed each ear individually, and we also assessed the child. And so in our perspective, no, it hasn't really changed things. You've still got, what we have now is we've created a group of children that with one ear in and one ear out that we can't implant, because they're very, very specific now that the hearing loss has to be in both ears. So for our experience, no, hasn't changed it drastically, but obviously it's still early days.
Natalie, perhaps I could ask you how your criteria compare to this. Do you have similar levels and similar testing regime there? Or?
Yes, it's about the same. They have to have bilateral severe to profound. And so, but we are not checked as much. So if you have a child that has moderate hearing loss and a severe to profound on the other side, and the child is not doing well, or has fluctuating, or has a high risk of getting worse, then we are a borderline, but we are authorized to have a small amount, like 10% of cases that are borderline. So we can explain that to the authorities whenever we have double check about.
That's really interesting, because for me, I think the thing I would have liked to have changed is not so much the criteria, but the flexibility within them, so that we can use that judgment. But as Ian said, I think ours a little bit more rigid. But this brings us on actually to the issue of neuroplasticity. And one of the most, I think, interesting areas in the field at the moment is this talk about the age at implantation. What's the optimal age to implant a child? So James, perhaps I could ask you, why don't we implant children who are 3 months old? What's the kind of, perhaps you can explain to people the rationale?
From the neurodevelopmental point of view, the obvious time to implant them would be at minus 12 weeks, because that's when the normal auditory system starts to work. Some sort of intrauterine surgery would be the optimum if you really had to have it. If you want to normalize these children's auditory experience, you give them sound prenatally. And obviously these children are denied that. They're then born, and then there's a bit of hoo-ha and deciding that they're actually deaf, which usually takes a few weeks at the start. And if we take a child who's then unequivocally deaf, so they're not one of the ones that are on the borderline that Ian's talking about, but we're absolutely sure that they're deaf, then actually there is really no reason to delay from a neurophysiological point of view, because the sooner you implant, the better the long-term outcomes. But there is a balance, is that the surgery, while not at all, not hazardous, I mean, a tonsillectomy is probably more hazardous than a cochlear implant. It's several hours surgery if you do one side, a 3 or 4 operation if you do both sides at once. In a small child who's got a small head, they're probably only, under 3 months, they might only be 5.5 kilos at most, maybe smaller than that. So you start to get into the realms where actual surgical risk becomes more of an issue. And so then it's a bit of a trade-off. The other thing I think that needs bearing in mind is that the evidence is not strong that if you implant under about 7 or 8 months, that actually it makes much difference to the outcomes. Between 3 and 6 or 7 months probably doesn't make much difference. There is pretty clear evidence that if they're over a year, then you've missed the optimum window. So I think that that's a really good number if you're thinking about when the child should have their implants. Really, if they're unequivocally deaf on the newborn screen and they're a straightforward case, and they're getting to above 1, then you have to think, well, why are we waiting any longer? Because actually, as they go on further, then they may have a worse outcome. That would be my view. I think that's probably how most people feel.
Yeah, I think for an exam perspective as well for the UK trainees, that we're waiting for a little bit longer, because ideally we'd like behavioural thresholds. So we would like to complement our electrophysiological testing with some behavioural testing. The other thing to say is that with the very young, the anaesthetic risk is going to be higher. So you're going to have more reluctance from your anaesthetist to have a couple of month old child having a prolonged operation. but also there is some evidence, particularly from North America, that if it, as James said, if you implant under 12 months, well, you're going to get a better result. What you've also got to bear in mind is that you have to have all these tests. It depends on the structure of your health system, at what age they're actually referred into the cochlear implant program, because people may not be confident in their audiology early on. And then you've got to get a scan, and you've got to have your MTT discussion, and this takes time. So whilst you must try to implant under a year in a congenitally profoundly deaf child, there is the other important thing, which is coming to a stable map, i.e. Getting to a point where you're confident that that cochlear implant is programmed appropriately for the child. And the quicker that you can do that, the better. So you can, you may well implant a couple of months later than the centre down the road, but if you're quicker to a stable map, then perhaps you've limited that difference.
Yeah.
Just one quick point. I think that what's really interesting, though, and I'm sure Natalie has seen this, is the families where there's more than one deaf child. So the first deaf child, you go through this process and they come in at 10 or 11 months and you implant them. They have the second deaf child and they're sat outside your office door and the child's 6 weeks old and they're saying, why, just do it today, doctor. So in fact, the parents who've had experience almost always, if they have a second child, they vote with their feet and they're absolutely chomping at the bit to get on with it.
Yeah. And Natalie, I could ask you, perhaps, would you also be happy to operate younger if you needed to for a post-meningitic case where you started?
Yeah, I fully agree with all what have been said. It's a balance. Of course, earlier is better, but below a certain age, a certain weight, it's much harder, much more risk for complication. And as it has been said, also it's a combination of the background, the family background, social background. Are they ready for that? You have to push for earlier, but the timing has to be perfect for concerning also the environment and being secure. So before the age of 12 months of age, for sure. Before 5 months of age, I wouldn't push too much, just.
Okay.
Could I just butt in for a second? We had a question typed in from Andy about the need for CT scanning. And I don't know if you covered it or not. He said, would you use a CT scan for kids with charge and other inner ear malformations? Did you cover that?
We might move on to that, but I think the answer is yes. I think if there's, as James I think said, if there was inner ear abnormalities on the MRI, that would most of the time be an indication for a CT scan.
Okay, good.
Can I add something?
Yeah, Natalie.
Yeah, if you're an experienced surgeon in otology and especially in cochlear implant, you might not, if on the regular cases, you might not need the CT. But if you're less experienced, I would still recommend the CT, because you have some information about the facial nerve, the landmarks, and if you're not so experienced, I would still rely on that too. I don't know if you.
And I just add, with charge in particular, 100% I personally would get a CT scan, because those surgeries can be fiendishly difficult.
And
we might get on to that this time later.
In Charge syndrome, you not only have inner ear malformation, but you have middle ear malformation and you have vascular malformation. So you have to know how the landmarks, even after your incision, you can have some surprise there.
I find the key to charge cases to ask your colleagues to do them. So there was some interesting.
He's not looking at me, by the way.
No, there's some interesting work recently about the neurocognitive effect of a prolonged GA. Do you think carefully about duration of anaesthesia in a young child where there may be some cognitive impairment if you go over, I think they say 3 to 3.5 hours for a bilateral case? People talk about only having the most experienced surgeons, so it's done quickly. Is that something you're conscious of or not really too worried about?
Who are you asking the question to?
Well, Natalie, why didn't you answer first?
Okay, well, I would be concerned not for the neurocognitive, but in general, as a very young kid, you don't want to have a long surgery, especially if you're doing bilateral, when the child sits on the first implant and you have to do the second quickly, because you don't want to have a trauma for the flap. And So anyway, the shorter is the better, but you still have to have the trainees or the younger senior operate on. So I would be concerned of shortening, but at one point, if it's a regular kid, I would still let some other junior senior do it. I don't know.
So, okay, thank you. Let's move on then. I just wanted to bring in a topic that isn't talked about that much these days, but is still there, and that's the attitudes of the deaf community towards cochlear implantation. Certainly, I see it less now than perhaps 10 years ago. Would you agree with that? Do you think it's gone away? Is it still there in the background? Perhaps I'll start with Ian on this one this time.
Yeah, I think this is a really interesting topic, and it's something that we're actually looking at the moment in Manchester. So, certainly, if you look over the last 10 years, we've gone from no deaf signing parents bringing their profoundly deaf child to have a cochlear implant to the situation now where we're looking at our series, and we've got over 30 children where at least one of the parents uses visual language. So it is an interesting one. In part, it reflects the opinions of the deaf community around themselves and the actual hearing, but also I think it's partly our failing because I don't think we've got the message out. Certainly not dissimilar to what you're hinting at with your cartoon. We'll often have a scenario where the deaf parents bring their child in and they think that the child's going to be in for 5 days. They think they'll get a facial nerve palsy. They think they'll have a 20-inch scar on the side of the head. So we're not getting the information out there. But ultimately, there's two things I would like people to go away with. It's choice. And so if the parent's choice is for their child to communicate solely via using a visual language, well, that's their choice and that is their right. What I, as a cochlear implant surgeon, for those parents who are interested in receiving information, I think we need to get that information right, and it needs to be delivered in a way that they find easy to access, and it answers the questions that the deaf community want answered rather than the ones that we predict or we think that they should ask. So that's really important. And then the last thing I would leave you with is that it's not binary either. It doesn't mean that if you are we need to move away from people thinking that if your household are BSL users, that if you have a child that has a cochlear implant, that child can't use BSL. They can. So there are, if we think about adults that we implant who are postlingually deafened, then some of those adults use their cochlear implant as a benefit to lip reading or in difficult listening environments or whatever. So it's not binary, sign language or electrical hearing. It can be it can be both, and it can be both in different situations.
I think we'd all agree with that. So I think we'll move on from that topic now. But James, perhaps I come to you on the next topic, which is the issue of bilateral cochlear implantation. I think it's fair to say that the UK community was pretty shocked when this came in as a NICE approved intervention in 2009. Is there any debate at all now about bilateral being better in majority of cases? We may talk about special needs cases and other things later, but is there any doubt now that bilateral is better for?
I don't think there is, no. I think that the parents prefer it. The child has one operation. They get on with the rest of their life. They don't have two anesthetics. You always got, you're implanting the better hearing ear. They probably get some spatial benefits from having the implants, around the same time with a very short delay. It probably improves outcomes. There's pretty robust data on that. And then finally, and this is pertinent to me recently, we had a child who was implanting bilateral implants, and they come along 9 years later and with troubles with one of the implant, but then we have to actually a bit of a faff to sort out. But in fact, the child's still hearing on the other side. And if only for that reason that you've got two in there, it's worth it. So I don't think really there's any discussion. There are marginal cases in whom you can, there may be asymmetry in the hearing. There may be other factors that make you stay your hand a bit. But I think from the UK perspective, and from my personal beliefs and from I think that there's very little reason not to go ahead with 2 unless there's a very, very strong reason otherwise.
And Natalie, can I ask your view on this? Is that the same in France? Do you do a routine
Yes,
bilateral in children?
Yeah, well, again, as we started the screening on a later stage, there has been also a lot of discussion because of this one clinic that was very famous about testing vestibular disease in children, and was very concerned and loud about the vestibular dysfunction created by cochlear implant, and especially in bilateral simultaneous. So I'm completely fully agree with James, and we are proposing to, when we have early screening bilateral simultaneous very early on. There are some families that are a little bit reluctant, but most of them are really into bilateral. But some other hospital are just doing one side, and then second side after the second we have double checked the vestibular function. We can check the vestibular function very early on children, as soon as they're 5 or 6 months of age. So it's a good point of view to check the inner ear in general, cochlear and vestibular function in any hearing loss. So it's good to have this in view, and keep in mind that we have to protect the function of vestibular function even during the surgery. So that's good, but it doesn't have to hold back for the bilateral simultaneous.
Yeah, I agree with that, and I think in particular what we've found is that since we've been introducing soft surgery, so surgery that is designed to preserve inner ear structures, primarily that this was introduced to preserve fine structures within the cochlea, we're not seeing nearly as much post-operative imbalance in the older children and adolescents who can really tell us what's going on. So I think soft surgery, irrespective of whether you've got residual natural hearing that you can measure, doesn't matter. We still do a soft surgical approach because we're preserving fine structures within the inner ear.
Yeah. And James, perhaps that moves us on actually nicely to our next topic, which is the surgery. Ian's talked about soft surgery, which I think is pretty much universally accepted now. Perhaps you could tell us, for you, what the key points are that make surgery soft compared to a standard, or something perhaps we would have done a few years ago.
So the opposite of a rough surgery. So I don't think many people really do set out to do rough cochlear band surgery. I've certainly seen it happen, and I've done it myself on occasion. It's not always quite as soft as you would like. You want to be like Neil Armstrong touching down on the moon. There's hardly a dust cloud raised. Whether they landed on the moon or in Texas, it doesn't matter. It was a soft landing. And I think that's probably true. That the principles of the surgery are you want as small a hole as possible. You don't want to be raising big skin flaps or devitalizing tissue around the soft tissue, because in fact, actually soft tissue complications are a nightmare to sort out. We may come on to those. And they can be largely completely avoided by careful handling of the soft tissue before you even get to the periosteum. And then the other part that you have to be soft at is when you get to the round window. And there are everyone has their own slight way of doing things, but the principle is that you don't want to be drilling inside the cochlea, because you may traumatize the basilar membrane, you may traumatize the inner ear, you may cause blood to accumulate there, and that you may get post-operative scarring. And then finally, when you insert the device, you want to choose a device that's going to slide in nice and smoothly, and ideally will be positioned entirely within the correct component of the inner ear, and not translocate across the basilar membrane, because first of all, you're going to destroy any residual hearing, although it may not be important, but also you're going to perhaps have a less healthy ear in the long run if you start mixing endolymph and perilymph by traumatizing the basilar membrane. The evidence is not really there, I don't think, that in the long run it makes a great difference to the hearing outcomes, but it's probably, as it's just as easy to do soft surgery, it probably is a better thing to do, and you should aim to do it in every case. Even if it's not necessary, it's good practice for the hearing preservation cases where you actually have a pretty good marker for whether your hands have been soft or not, because you do the hearing test afterwards.
I agree with
Yeah,
that.
and one of the scenario is if you're born in the UK or Europe now, then without any other comorbidities, your life expectancy is going to be in excess of 80 years. So whilst we don't know necessarily how long a cochlear implant is going to last, you certainly will predict that child or young adult or adult would need another implant during their lifetime. And so if the principle of soft surgery is to limit intracochlear scarring and inflammation, then surely that will make it easier to put a new one in when the time when it's needed. The other important thing to say is we do use steroid in animal models. It's been shown to be cochlear protective, but we don't know what the dose is, when to give it, and how to give it.
Interesting question from a Mr. Quo from Birmingham being typed in, asking that if COVID's going to be going on and on and on, would we not be better taking the risk of the odd child catching COVID rather than just getting a great big pile of children waiting for implants?
Well, we're in line with a lot of other centres. We're about to restart within the next two to 3 weeks. We'll be restarting cochlear implant surgery, particularly targeting those children that don't have residual hearing, so they don't have access to sound. It's they're not, a hearing aid's not going to be any use to them. So those children are now moving towards elective surgery.
Natalie, you've been doing them in Paris for a while, haven't you?
Yes.
You started quite quickly.
We wanted, for us, it's a semi-urgent. I mean, just after when it settled a little bit, we pushed to start with the children that had no hearing or late diagnosis, just the one that were needed really as we thought. We sorted the cases. For the children that had a need for a second side, sequential or had residual hearing, they can wait a little bit, but the other ones are just going. So we started again.
Okay, so perhaps we can move on now to talk about electrode choice. I guess the biggest debate in this area is whether you're a believer in the position of the electrode within the cochlea making a big difference. So some people favour something that hugs the modiolus, other people prefer the lateral wall, so-called lateral wall electrode. James, perhaps I come to you first. What's your sort of go-to electrode in terms of position within the cochlea and length and that sort of thing?
Well, I think, I can tell you what I use, but in fact, I think that it's a little bit about how many angels dance on the head of a pin. I mean, there are, I think, some children who have cochlear anomalies, or they may have residual hearing, that you may definitely choose a certain electrode because you have a belief that it's going to do one thing over another. But for the great majority of children, actually, the difference is greater between the children than it is between the electrodes. I think you must use something that you're comfortable using. You must use something that you can put in softly to preserve hearing, preserve cochlear structure. And you must have something that you feel confident that, as Ian says, that in 10 or 15 years' time, you or your descendant, one of the registrars listening today perhaps, is going to be able to take out and change. And they're the things that I try and bear in mind. I think that the other thing is that different hospitals and different countries have quite different patterns of use of electrodes, and it probably comes down at the end of the day as much to financial as much as anything. If you go to Austria, everyone's going to get one type of electrode. If you go to Australia, everyone will get another type of electrode. But it's not that the Austrian children are different than the Australian children, it's just the way that it happens to be. So I'm not really strict on that. I think you need to think, though, because the main difference is whether you want a hearing preservation electrode that gives you the maximum chance of not damaging the inner ear, or whether that's not so much of an issue. But I don't know what the others think.
Yeah, no, I would tend to, I would entirely agree with you. I think there's a lot of, as you would imagine, within the pharma industry, there's a lot of money spent with these companies trying to say that they're better than somebody else, and nobody is universally better. It's like the analogy would be like playing a round of golf. You pick the club for the shot, and I think you've got to all of these companies have a range of implant electrodes, and so you have some options. Broadly speaking, for an exam perspective, you either have perimodiolus, so has some sort of spring mechanism, so the electrode, when it's activated, if you like, will tightly hug the modiolus. So the thought there being, if you think about each electrode on that array being like a child holding a torch, the further away you are from the torch, the wider the beam. So it's what we call spread. If you're on the lateral wall, so you're not next to it, then obviously the spread of that beam is further. However, you are less likely to damage residual hearing if you have a lateral wall electrode. The other thing would be thinking about the length of the electrode. And again, some companies say you need complete cochlear coverage. Another company would say, well, that's not needed because the spiral ganglion cells end before the apex of the cochlea. So I think perhaps the thing to think about is when we started trying to preserve natural hearing, if we think about the tonotopic representation of the cochlear implant, of the cochlea, like a cochlear duct, like a piano keyboard, that we use short arrays because we thought, well, the best way to preserve that residual low frequency hearing, which is sensed within the apex of the cochlea, is to go nowhere near it. But the problem was then is, do you have the concept of preserving hearing, and then you've got to maintain that preserved hearing. So the problem is you might put a very short electrode in, which is brilliant, and you've preserved all the natural hearing, but a year later, when the natural hearing is gone, that patient may not have as good an outcome because you've not covered enough of that piano keyboard.
Natalie, can I ask you, we've talked already, Ian and James have both mentioned revision surgery.
Yeah.
Does the thought that an average baby now is going to need two, at least possibly 3 implants over the course of their lifetime, does that influence your electrode choice the first time?
Yes, for sure. That's the only thing I wanted to add to what I agree with what had been said. I think some children has very specific needs, like very specific inner ear malformation. Out of that, we really have to think on the long term. And the first thing is not to hurt the inner ear and to think that one day this person will need to have removal of this. And the first surgery is the main one. If you traumatize the inner ear, then the second one, the extraction will be very hard, and then you get into trouble. If the first insertion is atraumatic and made in the proper way, then you are very less likely to have any concern for afterwards. So, and you have to think of the long term, 80 years from now, maybe there will be treatments or other things. So you have to preserve the structure. Yeah. And the second thing is, overall, the brain makes much of the difference. I mean, the brain is like 80% of the hearing. We think only peripheral hearing, but hearing is not only the cochlea, it's the nerve and it's the brain, and the brain makes a lot of difference. Some adults have been implanted a very long time ago, have only 8 electrodes still working, and they still can hear. So it makes a difference to a certain point, but we have to keep in mind to keep the the structure preserve the inner ear structure.
Blake Papton in Toronto always used to say that, I'm sure he still does say that, basically we're ear surgeons, so we think about it as being a cochlear implant, but actually it's a brain stimulator. That's all it is, a brain stimulator. Exactly. It just has to go in the ear because that's where it has to go.
It's like Jerry O'Donoghue, who calls hearing aids brain aids to try and help the adults reduce their risk of dementia. So I'm going to move on now to perhaps skip this one, move on to talk about hearing preservation, which we have touched on in terms of surgical technique. But I'm interested to know, Ian, I know you've done a lot of work. Well, in fact, you all have done a lot of work on this. But Ian, I'll come to you first. What do you tell this patient, probably a slightly older child, who's considering a cochlear implant? We'll assume they're not doing very well with the hearing aids, or perhaps you wouldn't be having that discussion. But what do you tell them about the likelihood of preserving that hearing?
As in all operations, you're better off to giving your own percentages, if you like. And how we actually measure preservation, of course, that's variable, and that limits the ability to sort of combine and contrast data. But again, I'd be really interested in this audiogram to know what the hearing was at 250 and 125, because the way it's going, that's going to certainly be normal, isn't it? So your options are, in a way. If so, they're not making adequate progress, or life's too difficult in the educational setting with their conventional hearing aids. So you say, okay, do you go for one? Do you go for two? And if you go for two, do you do the surgery in one stage, i.e. do a bilateral, or do you do a sequential bilateral? And it's a really interesting and difficult conversation to have. Our results with the particular electrode that we are most confident with are getting increasingly consistent. So we'll say to people, well, the possibilities you could lose your hearing in both ears for a few weeks, or you might lose it in one and not the other. And so again, it's a risk and benefit, and it's best if the young child or young person is involved in the decision-making process. But to be honest with you, whilst I know plenty of people that would say I wouldn't offer bilateral simultaneous, I've got to say that I'm so confident in the electrode now, I would of course tell them of the risk, but I think more than 80% of the time we can preserve, in this sort of audiogram, we could preserve some hearing that is useful. But again, coming back to what we talked about, problem at the moment is we can preserve the hearing, but we don't know how to maintain it. And that may come in the next generation of cochlear implants, which are drug-eluting. So either they're releasing some sort of neurotrophic factor, steroid, or whatever. So it looks like from the literature that if we preserve the hearing, it's at least maintained for a couple of years, but often it just drops off a cliff when you do that. So some patients will say with that, okay, well, I'd rather just have the operation, except there's about an 80% chance I'll have something in those few weeks until I'm hearing electrically, and then go from there. And then one last point, it's interesting. You are preserving structure, so that is important. What does preserved low frequency hearing do? It seems to help with some aspects of intonation. It seems to help with music appreciation or listening in background noise. But it's, it's not an absolute game changer, but it is important to try to preserve it. And the last thing is, our adolescents that have really good, let's just say with these audiograms, we've got a cochlear implant in there, and they've still got that audiogram, because some of them do. It's interesting that the majority of our young people still want the cochlear implant programmed, thinking about that sort of piano keyboard, if you like. They don't want half the piano keyboard switched off. They want it programmed without consideration or reference to their natural hearing, and we don't really understand that at the moment.
Natalie, I'll come to you, and then James, I'll come to you after. What would you like to add, Natalie, to that?
So the thing is that usually we look at the audiogram, the tone audiometry only, and what is very helpful also for decision making for families and for the teens, because they look at their audiogram and they say there's a lot of hearing, we don't want to lose that. But what is the everyday life use of this hearing? So we have to look also at the speech intelligibility rate, and especially how they can hear in noise, because usually it just fell off. I mean, you have maybe 80% of hearing in a booth, in a silent environment, but that's not real life. And when you do the testing in noise, it just drops so much. They understand how much they can gain. So it's not just looking at the tone audiometry. It takes a huge step forward, because that is where they will have the first help. Second thing is that sometimes it's hard to have bilateral simultaneous, because in the meantime they have the switch on, they have no hearing, or they have very little hearing. So that's why you can manage saying, okay, well, might be doing both and keep the hearing aids until we have stabilized on the other side. But that's just options you discuss with the young people or with the patient, the parents.
And James, what would you like?
I think that was a brilliantly chosen audiogram, actually, because that audiogram, you could have a whole hour seminar on just that audiogram. In fact, it's absolutely right on the money. which is probably why you chose it. And I think for the registrars listening, who for both adults and children, the reason you should take a photograph and think about that audiogram is it illustrates several really important points about hearing. The first is that low frequency hearing, that is below 1 kilohertz, is not useful for speech understanding. It is almost irrelevant for speech understanding. All of your speech understanding is 1 kilohertz and above. So that's the first thing. So if you see an audiogram like that, they're probably suitable for a cochlear implant. Secondly, the other point is that the 1 kilohertz is at 60 decibels, and that is, in my experience, is a key point. If the 1 kilohertz is above 60 decibels, they're usually managing with hearing aids, and they don't want a cochlear implant. And if the 1 kilohertz is at 60 decibels or below, they have lost that last little tiny bit of understanding of the high frequencies, and then they're better off with an implant. The second thing I would say about that, and I agree entirely with what the others said, I would do a bilateral implant for a child like that if they wanted to go ahead and were otherwise suitable. But the other thing that I would say is that although an implant, otologists can be a bit, shall we say, pernickety.
Surely not.
Yeah, it can happen, Mike. And you'll go to meetings and people will present the most astonishing data about how the low frequency, these sort of the benefits of maintaining the low frequency. We all sort of beat our chest because we don't have cancer to deal with. So preserving those decibels in the low frequencies, that's Ian and I's arm wrestle at meetings, and we should like to show how we've done it. But the bottom line is the patients are largely like Bob Dylan. So Bob Dylan in 1966 went from acoustic to electric, and he played a tour in Manchester, actually, famously, where he played the first half of the concert acoustic, and everyone's clapping along to Mr. Bojangles. And then at the interval, he comes back and he'd gone electric with a different band. And the crowd are booing him and shouting Judas and all the rest of it. But the bottom line is, if you listen to that concert now, the second half, the electric half, is outstandingly better than the first half. And the children vote with their feet. If you implant a child like this, they never say, oh, I love, even if you preserve their hearing perfectly,
yeah, exactly.
They like having the low frequency because they say, when I don't have my implants on and mum calls me for tea, I hear there's something going on and I come from a tea. But they like their electric, they go electric, and they are 100% committed to electric, and they often don't even use a hearing aid processor if you fit them to them. So because they love those high frequencies. It's like hearing crack cocaine, the high frequencies.
Great, thank you. I'm going to move us on.
Good answer.
Because you can't beat Bob Dylan crack cocaine. Next time.
Okay.
James, I'm going to stick with you actually, because I know you've got one of the largest experiences in the UK of Carina. So I've picked this audiogram as an example, and obviously it's difficult without specifics, but this is a sort of case where you've perhaps got options. And how often do you see the situation where you're sort of, perhaps without going into specifics of any case, but generally, how often do you have a situation where you think, this could be a middle ear, it could be a bone anchor, or it could be a cochlear, and you're sort of having to choose between them? Or do you find you're always pretty clear that when it's in the threshold, you're going for a cochlear implant?
Looking at that audiogram, I would always think, could I use a middle ear implant? And I almost always decide that's totally unsuitable. And I'm a bit suspicious of an audiogram like that because, and I think again, for the registrars, you look at the air conduction threshold, you can be pretty clear cut about. But the bone conduction that the audiologist is marked, that might just be they're getting vibrotactile. It's a rather suspicious bone conduction. It could be actually completely sensory neural. So I would have to be really persuaded that there was a reason why they would have better cochlear reserve. On one, if it's not easy to mask on one side, it's quite hard to tell which side that might be. In fact, although it's marked on the right. You can't really mask that.
It's unmasked. Here it's unmasked.
Yeah.
So
I think Steve, I think James will be able to confirm it, and Natalie, but I think I understand it that the Carina's been withdrawn from the market.
It has been withdrawn. It's not suitable for under 14-year-olds anyway, and I would be looking at a cochlear implant on a child like this.
Yeah.
Explain to me very gently what a Carina is, because I'm not really.
I wouldn't get too excited because it's just been withdrawn from sale. But basically, it's a powerful sort of vibrator that you can attach to any part of the ossicular chain. And what's not neat about it is that it's very powerful, and B, it's completely under the skin. But it's a bulky bit of kit, and it's only suitable for adults, and I just think it's been withdrawn, not because it was a duff bit of kit, but because I think it's not profitable, because the number of people who need it are not very great, in fact, and so it's just...
Yeah, I think there was 400 to 600 people, I think, around the world that received them. But the shame is that I hope it doesn't limit the evolution of implantable microphones. And that's because that's what you had. You had a fully implantable hearing aid that, like the evolution of cochlear implants, it may well have been the forerunner of something else. So let's hope it's not the end of that story.
I agree. So we're going to move on to talk about a couple of topics now that are quite common exam questions. And this is sort of management of infections in cochlear implant cases. So we'll start with the commonest, which is the child with recurrent acute otitis media. And we'll assume you've tried some sort of conservative measures. Well, perhaps I could ask you, perhaps, Natalie, I'll come to you first for this one. Would you use grommets in a child with a cochlear implant who's getting recurrent acute otitis media? It's sort of uncomplicated recurrent acute otitis media, or would you try and steer clear of them?
For sure. As soon as I plan a surgery, I need a clear ear. And if the child had recurrent, I keep the grommet even though I had done the surgery. And if the child hasn't got grommet, I do it afterwards if needed. We don't want any acute or chronic ear after the surgery. There's always the risk for meningitis. There's always a risk for complication, infection on the implant, electrode array. We don't want any infection there.
And Ian, perhaps I could ask you, would you try your prophylactic antibiotics in this child, or would you tend to have a lower threshold for putting grommets in?
No. And if you asked me 10 years ago, the way we were taught is that you try to avoid a grommet because you felt that was going to, be a conduit or a route in to the middle ear for infection. But absolutely not. The Europeans have been far ahead of us in this regard, and so now I have a very low threshold for inserting a grommet if a child's having recurrent acute otitis media after surgery, and likewise if I'd put a grommet in before the surgery, be it for glue ear and threshold assessment or because of recurrent acute otitis media, then I would leave it at the surgery. The days when I would be patching it and all this sort of stuff at the time of the surgery, I don't do that anymore.
And James, perhaps for the next case, we'll come to you first. This is the child obviously with an acute mastoiditis. We'll assume it's a child who's got a cochlear implant in. Do you have a lower threshold than normal for draining this surgically, or are you worried about damaging the implant by doing so?
I am worried about damaging the implant. I mean, you certainly, first of all, mastoiditis is, I think, a bit less common in children with cochlear implants because they've had the mastoid all opened up and it's all ventilated. But when they do get an ear infection, it goes red at the drop of a hat. Because there's often, they haven't regrown completely the cortical bone.
Yeah, exactly. Any
bit of otitis media, they go red right away. So we see quite a lot of these kids. I think I personally wouldn't leap. If a child is well and it's not obviously a great big fluctuant mass, then I would certainly try some intravenous antibiotics like ceftriaxone and an overnight admission and see how they go. If it's purulent and fluctuant, I think there's pus in there, then I usually would just make a tiny little stab incision. And we're fortunate in Oxford in that all the surgeons who put the implants in do it in basically exactly the same way. And you can be pretty sure where the wires are going. So we make an incision where we think the wires aren't, just make a little stab, open it up with some forceps. I wouldn't drill out the whole mastoid because then you're going to get into a world of pain where you start to damage the implant. Just maybe a little drain and it will almost always settle down without anything else needing doing. It's more tricky if the case comes from another center and you're not quite sure where the wires might be running, in which case you just have to be very, very careful.
I would use a needle to puncture and take some of the pus out if it resists to antibiotics, and maybe put a grommet. Usually it just settles down. It's very impressive, but after cochlear implants, it's not a big deal.
Yeah.
I agree. What about this next case where we're starting to see some extrusion?
Not good.
Perhaps
not good.
Perhaps the acute infection has settled down. You've tried your IV antibiotics. Perhaps it's even settled temporarily on some IV antibiotics. So the question is this salvageable? Ian, what's your experience of this?
Oh, it makes me sort of wake up in a cold sweat. I can say that thankfully they're very rare. These sort of, but it's been my experience that once you start seeing the implant, I can't save it, and I can tell you that we've tried advancement flaps, we've tried prolonged intravenous antibiotics, we've tried just and taking an ellipse of the unhealthy skin, smothering everything in betadine, and all of these sort of things. And I think we've tried it, as I say, because it's thankfully rare, 3 or 4 times, and we have a success rate of 0% in saving that implant. It is interesting because I have spoke to colleagues that I am certain, I believe their experience from Israel, and
Ian, you dropped out a bit.
Able to save these implants. So I don't know whether the bugs are different.
Does anyone else have? I mean, my experience is once you've got a biofilm on there, it's a goner. Natalie, do you?
Yeah, we don't like those. The same. In our experience, it's 2/3 of the implant has to be removed. You only save 1/3 of them, and depends how long it has been going. You still need to have the antibiotics tried on, but usually the flaps, etc., doesn't really help. It depends also if it's spontaneous or if there's any trauma that has been starting there, and maybe the placement of the casing is very important. So also right at the beginning, when you put the implant, you have to think you don't want anything sticking out under the skin, especially in very young kids, because it's very thin. The skin is very thin. And if the implant is a bit sticking out, then on the long term, you can have some local trauma, mechanical trauma, and then lead to this. So it's also the initial techniques will impact on the long term.
Do you think we've seen more of this since we've stopped drilling wells? It's not my understanding.
Well,
no, it's still rare, isn't it? Thankfully.
Yeah, they keep, but now the casing, the internal part is thinner. It used to be too, so I think it helps too.
Why did you stop drilling wells?
I do drill. I do drill a bit the bone to make it sure it's just under the skin.
I use a technique. I don't drill a well. I create a tight periosteal pocket, but I definitely drill a channel for the electrode cable on the lateral aspect of the skull, because that's when you remove a failed implant after trauma, that seems to be where the problem has arisen.
Yeah.
When I do my PhD, when I retire and I have time on my hands, I think one thing that's really interesting is that this sort of case, you can read the serial number on that implant. If you can read the serial number on the implant, it's a goner. It's had it, in my experience. So that's, I think, it's probably not going to survive. What's interesting is if you get infection around the receiver package up there, it's that's it, we're done. But you can get the most appalling things happen to the electrode in the mastoid in the middle ear, cholesteatoma, infections, granulations, glue ear, mastoiditis, rada. And you clean it up and tidy it up, and as long as the receiver package isn't damaged, you've got a pretty good chance of saving that implant in the long run. There's something immunologically different about where the package bed sits in the soft tissue and under the periosteum in the scalp, and the mastoid middle ear component where the electrode sits, because the properties of infections in those two seem to me very, very different, and it's much more salvageable if it's a middle ear mastoid problem.
I agree. I'm going to move us on because we're coming towards the end of our time now. So perhaps as a final but quite important topic, we'll talk about children with additional needs. We know that probably 30% at least of children having cochlear implants have some kind of additional need. So Ian, perhaps I'll come to you first and just ask in general terms, if you see a child with complex needs, what kind of issues, just in general terms, are you sort of considering in offering this child cochlear implantation?
Firstly, I think that your last part of your sentence or question was the most important thing. We would still consider a cochlear implantation in a child that had a physical impairment or a cognitive impairment. But again, one of the first things you've got to think about is you've got to make sure that their access to sound is already maximised. And you've also got to think about, well, what would a cochlear implant do? And just because at the moment we don't have the right tools to measure benefit in children with cognitive impairment, it doesn't mean that their benefit will be any less important. And you may well need to look at what a benefit will look like. It may be that a child with, I don't know what the particular pathology is, but let's just say that child has cerebral palsy. It wouldn't be realistic necessarily to think that the child will develop intelligible speech. But if that child is able to interact with its mother and family in a much easier and enjoyable way, then that is still a triumph and an important thing for that child. In terms of the surgery, do you do one or two? How confused, this concept of, well, should you do one, see how the child does? It is difficult, I think, for children with a cognitive impairment to sometimes adapt to that second implant, but I don't think that would preclude thinking about it. And then the last thing is that child's in a chair, so you've also got to think about retention of the cochlear implant. So if you're going to put the cochlear implant in, you're going to put it in fairly vertically because you want to keep the coil away from the headrest. So it's going to be really important to talk to the parents about their experience of wearing hearing aids, for example, prior to coming to see you.
Natalie, anything to add for the child?
Yeah, well, we also same completely, but I would say also those children, some of them will, most of them, I would say, might not get into, they will hear, but not get into language, because language is another issue. And on the long term, I've seen those children on the long-term follow-up when they become teens, and they are in very specific environment as to scholarship, and some on the long term become non-users. They have overall a higher risk of becoming non-users because their environment with sign language, or because they have other disabilities that, like autism or neurological impairment. But still, it's worth trying because you never know how it will turn. But the counseling of parents are very specific in those children.
Yeah, no, exactly. Can I just say one thing, Stephen? Sorry. The literature would say that the child's cognition will affect outcome. But actually, although there aren't hundreds and hundreds of cases in the literature, the evidence that is there shows that really motor function, that motor component of any sort of cerebral palsy, for example, that has little or no impact on actual success, if you like, what the child can do with their cochlear implant. It's all about cognition. It's all about your central processor.
Yeah. And James, would you be more likely to offer a single implant to a child who's perhaps in a chair and difficult reduced mobility, or are you still generally going for bilateral in most cases?
I think these are really difficult discussions. I was listening to what the others say. I mean, I think these children are really hard to know what the right thing to do is. In fact, the part of the issue is that these children often pitch up at the age of 1 to 15 months. It's actually it's very hard to make a really accurate prediction about what their cognition is going to be like when they're significantly older. So having had that, if it's a young child and you have that discussion, and in fact the direction of travel then is you say, well, we don't know what it's going to be, let's give them the best shout. So in fact, quite a number of our children do end up with bilateral implants because we say, well, if they're deaf and we think they're going to benefit, and we do that for a hearing child and we think they benefit more from 2, what's different about this child? I think there is definitely, it's shades and shades of grey, and I honestly don't know the answer.
I'm going to move.
Each case are different, yeah.
Yeah, I agree with. It's very difficult, as you say. Let's move on to the last slide now.
Okay.
So I think next slide. Sorry.
Oh, pardon me.
We've touched on some of the anomalies and things previously, so I'm going to move us on to the end now. And ask you each to predict the future as a sort of parting shot for this session. We've talked a bit about COVID, and we're assuming that we're going to go back to doing routine implants. But if I had to ask you that, what do you think is the one thing that's going to change the field of cochlear implants in future? I'm not talking about small changes to electrode design or surgical technique. What's going to be a game changer in the next, say, 5 to 10 years? Perhaps I'll start with Ian.
The cochlear implant as a drug delivery unit, so delivering drugs, cells or genes to the cochlea.
And Natalie?
I would add improving our knowledge on the brain, because we know it's a connectome. Some children are disconnected in central nervous system and doesn't do well with the implant, and we don't understand why.
Yeah.
And so better understanding this will be a big step forward.
And James?
I agree with both of the others, which were on my list. And the other thing is completely implantable implants by hook or by crook, making it so they're completely underneath the skin, so that you can hardly even tell that these children are deaf, except that they're able to listen to their telephone from the next room, which a normal child can't do.
Excellent. Thank you all very much.
Yeah.
Thank you. Very insightful.
That's terrific. So before we go, I'd like to just bring up a few more slides. VAPO is going to happen in the 18th of September in Birmingham, and we are confidently expecting it to go ahead, although obviously things going on with COVID, but we're thinking that by that time we'll be able to have meetings. And the hall that Mike has found in Birmingham to hold it in is so big that even if 100 of us turn up, or 200, we can still be 2 meters apart from one another. So have no fear. And he's assembled an absolutely fantastic international panel. ESPO has been rearranged from this year. I mean, we should realistically be out there now enjoying the sun and the wine in Marseille, but we're not. So it's going to be happening in February next year. And I have got a slide for Liverpool, but stop press, I believe Liverpool has been postponed to a year later as well. Am I right in saying that, James?
Yes, you are. 2023.
So more to follow. Okay. So I would like to finish by thanking the international panel, particularly Natalie for coming all the way from Paris, which I'm sure is fantastic this evening, and James, who's come all the way from Oxford, and Ian, who seems to have dropped off the radar, coming from Manchester. This is going to be edited up a little bit, and it's going to be put on the VAPO website, YouTube, and the AOT website. Next week, we're going to have another one on next Tuesday, revolving around failed extubation in the hospital and the treatment thereof. So it's about acute subglottic stenosis and so on. Right. Thank you very much, everybody. That was great fun.
Thank you.
Thank you. Thank you.
Goodbye.
Really good. Thank you very much.